This case is something quite interesting. And what is this child? The subcutaneous mystery. This 5-year-old child from Virudachalam brought with a history of subcutaneous swelling involving the right inguinal region. The swelling in this inguinal region is there for about more than 18 months duration. The child was started on ATT elsewhere, but there is no response. Investigations done outside. Manto turned out to be negative, CB not negative, contact negative, no similar lesions elsewhere. The child was started on ATT and there is no response. The mother is running between pillar and post, and the child is referred to ICH at the end of 1.5 years of treatment without any diagnosis. But they did their best. Okay, right. So, what are all the possibilities? Can it be a subcutaneous mycosis, basidiobulomycosis? The only invasive fungal infection that can occur in immunocompetent host is subcutaneous mycosis. Could it be due to, let me try for an KOH mount or a fungal culture? Let's see. Could it be a malignancy? Sometimes a T cell lymphoma can have a peculiar manifestations like this, and anaplastic large cell lymphoma can have a manifestations like this. I don't know what it is. Retained foreign body. Any complaint which recurs on the same place or persists on the same place for about weeks or months to years together, rule out a congenital malformation or an anatomical defect, or it could be due to a retained foreign body. Chronic antibioma, partially treated abscess in an immunocompetent child, otherwise the child is absolutely fine, less likely. TB cold abscess. Cold abscess usually in that area tracking down from psoas abscess, unlikely, or could it be due to involvement of underlying hip joint TB arthritis, but there is no restriction of hip joint movements. There are no signs of inflammation too. Could it be due to non-tuberculous mycobacteria, which is very, very challenging? Do I need to take the sample from that area for MG80, mycobacterial growth indicator tube system? We are planning. Paniculitis, a vasculitis, but there are no skin joint mucosa, serosa involvement or no generalized subcutaneous swellings to suggest an autoimmune disorder or an autoinflammatory disorder. Primary immunodeficiency. When some problem involves the same site again and again, it is unlikely be due to primary immunodeficiency or inborn errors of metabolism. Majority of PIDs will have multisystemic involvement, multisystem involvement. Infections at multiple sites, unlikely, and it recurs. So I don't know whether I need to do investigation or not. Scabies with secondary infection over that particular area without any involvement of extremities, again unlikely. Okay, so the following investigations were planned at ICH, our institution: ultrasonogram, MRI, biopsy, special stains for fungal, bacterial, what else? CB naught again, cytology again. What we need to do? The child had received multiple antibiotics like cephalexin, itraconazole, ATT. But do I need to try antiviral? I really don't know. Multiple biopsies were done. First biopsy, June 2023, acute inflammation with no evidence of granuloma. Second biopsy done, necrosis, caseation is not mentioned. Third biopsy, again giant cell granuloma, again multinucleate giant cells was mentioned, but there is no mention on caseation. So what it is? When caseation is mentioned, right, Raleigh, you can say TB in a country like India, but caseation is not mentioned here. So what could be the diagnosis? Then we asked the surgeon to take a significant sample, and a punch biopsy was done, which revealed a granulomatous reaction with the abundant eosinophils, possibility of parasitic etiology. This is from one side. The next side is, again one more report says that, again there is a possibility this is a necrotizing granulomatous inflammation with abundant eosinophilia, probably a degenerated parasite. So what is this? This is a localized subcutaneous swelling with the granuloma and eosinophils. What is this case? This is nothing but a case of, so what we did, let me say first. The child was started on 4 weeks of steroids. 2 weeks 1 mg per kg followed by another 2 weeks 0.5 mg per kg tapered and stopped. So the problem was there for about 18 months, so many drugs, but finally we started the child on steroids. There was a brilliant response to steroids. Look at the picture at the end of the treatment, absolutely fine. So what is this disease actually? This is nothing but a localized eosinophilic cellulitis, otherwise known as Will syndrome. Today, I really don't know, is there any case report of Will syndrome or eosinophilic cellulitis in pediatric age group? I really don't know. A small discussion on this syndrome. So it can manifest as a pruritic plaque, can be vesicle, bullous, nodules, anything. Pruritus was mentioned, but pruritus in our case is not that much. Usually non-tender, no response to antibiotics. Blood count shows peripheral eosinophilia. This is there in the literature, but in our case, there is no eosinophilia. May have constitutional symptoms. In our case, there is no constitutional symptom. Elevated IgE and AAC. We didn't do IgE, but AAC is also normal in this case. Often self-resolving, but this case required a dose of a 4-week course of prednisolone to subside. Recurrence common. So far, after completing the treatment, the child has been asymptomatic in the past 1 year. Dermal eosinophilic infiltrate without any vasculitis. That is what there in the pathology report. So what is this syndrome? Well syndrome, or otherwise known as localized eosinophilic cellulitis. I need to thank our pathology for this report so that we could start our steroids with confidence, and by God's grace, there was a beautiful response. Thanks a lot for your patient listening. Bye-bye.